Okay, I think we'll get started. So as I said, my name is Ijal Brennan, and I'd like to introduce you to Colin McCann. He's the project manager, and he's in charge of the webinar today. And then I'd like also to introduce you to Deirdre Toon, who's the chief pharmacist for Sligo University Hospital. Okay, so we're going to get started. So here in community healthcare of Cavan, Donegal, Leitrim, Monaghan, and Sligo, we are developing a falls prevention framework. So I'm just going to share a few slides with you. Okay. And as I said, I'd like to all, first of all, before we get started, I'd like to thank you all for attending our webinar today, where the Meditation Review Working Group will present its key findings and recommendations in relation to falls risk increasing drugs. And we're going to seek feedback from you who are working in this area. Before our webinar begins, I would like to inform you that this webinar will be recorded and transcribed. So, the cost of falls-related injuries in older people is expected to reach 2,043 million by 2030. The Department of Health has showed a 10.5 population increase since 2013, with the largest change seen in the over 65 age group between 2013 and 2022. The number of older adults is expected to almost double in the next 20 years, with the greatest increase in those aged 85 years and over. In the recent NACA Major Trauma Report on older adults from 2017 to 2021, falls less than 2 metres were the predominant mechanism of injury for 82% of major trauma presentations in people over the age of 65, compared to 39% in the younger cohort, and 70% of those falls occurred within the homes. In addition to personal distress, falls and falls-related injuries are a serious healthcare problem because of their association with subsequent morbidity, disability, hospitalisation, institutionalisation, and mortality. So the scale of the issue within our own area of community healthcare of Cavan, Donegal, Leitrim, Monaghan, and Sligo is that there was an average of 3,347 falls-related admissions to acute hospitals per year between 2020 and 2023. So this resulted in an average of 36,196 acute bed days for falls-related admissions to our 3 hospitals of Letterkenny, Sligo, and Cavan. And the average length of stay after fall was greater than 10 days. So these figures do not capture unreported falls or injuries managed at GP or primary care level. And also those, attendants at AD that do not require admission. And it doesn't cover, the impact of falls-related injuries on individuals, for example, in their workplace, family life, and caring requirements. So we're heading for a falls-related crisis in our health system, if we're not there already. But as we all know, many falls can be prevented, and falls and injury prevention needs multidisciplinary management. So this is why we have decided here to develop a falls prevention framework. So the purpose of the framework is to support the implementation of an integrated, multi-agency, multidisciplinary, lifelong approach to preventing harm from falls, with the aim to reduce the number of falls causing harm to our population as a consequence of age or disability. Addressing this serious public health issue requires a cross-sectional, collaborative, whole-system approach to promote healthy aging, preventing falls, managing falls, and supporting people at risk post-fall. The biggest opportunities for promoting healthy aging and preventing harm from falls are in community-dwelling older adults, where the main cost drivers are ED admissions, hospital attendance, and continuing care. So the aim of this framework is to provide guidance for local areas on implementation of such an evidence-informed approach. The purpose of the framework is to support the integration of a multi-agency, multidisciplinary working to prevent harm from falls. And the framework will contain recommendations in relation to medication review, residential settings, incontinence technology, environmental issues, exercise and bone health. The framework will be informed by national and international best practice, including World Fall Guidelines and the Australian Fall Guidelines. The framework will provide the basis for a falls prevention implementation plan. So this is our progress to date. Okay, each working group has not only had to assemble evidence in line with best practice for their particular area, but has also had to understand it, synthesize it, and convert it into practical advice in the formation of key findings and recommendations for the development of this framework. So now we're currently in the period of review with your help getting feedback on everyone's work to date. And the aim is to have the framework written up by the third quarter this year and hopefully printed by the fourth quarter. So we're hoping this falls prevention framework will have the potential to contribute to service development, improve quality of care, promote education in falls, support clinicians in their clinical practice, and will hopefully stimulate the development of falls prevention services to help people keep doing the things that they enjoy doing and doing well by minimising their falls risks. The purpose of our webinar here is to seek your feedback as experts working in this field to ensure that the framework is a document that can be benefit to all. So today, as I said, we're doing the medication review, and we have 3 more webinars this week. We're covering bone health, strength and balance, environmental and structural considerations, and residential settings. The remaining working groups focus on areas with limited or emerging research, which is incontinence and technology. So please note this document is aimed at adults aged 50 years and older, as the majority of existing research relates to older adults. Expert opinion would indicate that much of this work is also applicable to people with intellectual disabilities and complex enduring mental health issues. The work represented here draws of this document is to offer health organisations practical recommendations for clinical practice and organisation policy in the prevention and management of falls and harmful falls, including bone health. These recommendations, as said, align with national and international best practice in the World Fall Guidelines, Australian Fall Guidelines, and the Affinity Project. So, without further ado, I am now going to hand you over to Deirdre Stewart, who is the Chief Pharmacist working in Sligo University Hospital, and she's going to do our presentation on the root falls risk increasing drugs in an Irish context. Thanks, Jen.
Okay, good morning. My name is Deirdre Stewart. As Edel said, I'm Chief Pharmacist based in Sligo University Hospital and working with older person services in Sligo and Leitrim. And today I'm going to be talking to you on behalf of the Medication Review Working Group on a project that, as Edel said, we've been involved in since 2022 in the area of deprescribing of falls risk increasing drugs. So I suppose I'm conscious that this presentation today is slightly different to previous ones, and this is going to be a peer review presentation, and that the people here today are very close to the decision making and the clinical appraisal that's really at the heart of this document. So I suppose the aspiration or the aim for today is that we would take your recommendations and your expertise into creating a document from the medication review end of things that would be accurate and that would be relevant to practice. So the talk today, it's approximately 30 minutes in length. We have a little bit at the beginning, and apologies to those that would have heard previously on where we came from in identifying our objectives. And then we're going to go into 2 sections, the first of which is the recommendations that our group has made in terms of medication review. And secondly, into the guidance document, which, to be fair, took about 99% of the last 2 years from our group to produce. But we'll go into a bit of depth about that. Okay, so as Edel went into in good detail there, our falls prevention group was established in 2022. Sorry, you're right. Yeah, go for it.
If you just put it on presentation mode,
Okay.
our screen will be much better.
Oh, okay. Yeah, no problem at all. Okay, thanks. Thank you. Thanks, Colin. Okay, so yes, we set up in 2022 with Jerry Clerkin as Quality Patient Safety Chief there, and Edel is our chairperson and Colin is our project coordinator. And the aim at the time was very clear, to reduce the number of falls causing harm to the population then of CH, CD, LMS. And the objectives of that group then were to develop an overall framework which would provide guidelines for healthcare and other professionals working with older adults. Within that, to identify and assess the risk of falls and outline the interventions to be offered as part of a person-centred approach. And finally, to implement this launch ethos of right care, right place and right time. So back then, Jerry and Edel identified the World Fall Guidelines, which had been recently produced, as the basis on which to develop their framework. And our own group, as the Medication Review, our work very much stems from those as well too. So the World Fall Guidelines 2022 has a good section on medication review, and they have 4 recommendations, 2 an assessment and 2 an intervention that they came up with. So they recommend assessing for falls history and the risk of falls before prescribing potential fall risk increasing drugs for adults. They recommend the use of a validated structured screening and assessment tool to identify these FRIDs when performing a general medication review or a medication review targeted to falls prevention. And the interventions they recommend is that a medication review and appropriate deprescribing of these drugs should be part of a multi-domain fall prevention intervention. And the last one was specifically targeted at long-term care residents, obviously very high risk for falls within that cohort. So they recommended that the falls prevention strategy within those long-term care facilities should always include the rational deprescribing of FRIDs. So as you can see, great focus there from the World Fall Guidelines on the importance of medication review in reducing falls risk, and an emphasis on using a tool, first of all, to identify the FRIDs and to deprescribe those FRIDs. So we drew our objectives from there, really. So we came up with 2. We wanted to have a series of recommendations on how medication review should look like for our population, for those people at risk of falling or who have had a fall. And secondly, guidance. We were particularly interested in this because of the very strong recommendation to use a comprehensive, user-friendly tool within the World Fall Guidelines. But a lot of us within the working group had been very involved in this at this point anyway, in terms of review medication for old persons. And the guidance that we would have used at that time would have been based, we would have used primarily NHS guidelines on the old red, amber, green way of doing things, which was great, but it was very much based in the UK and it didn't cover all the medications that were available for us here. And likewise, we had medications here that they didn't look at either. And then by 2019, 2020, Stop Fall came out. A lot of people are very, very familiar with Stop Fall and the work of that group. Very ambitious project to gain consensus across Europe, looking at national fall guidelines and all the evidence that was there, to gain consensus on what we would consider a falls risk increasing drug. And further than that, they looked for agreement where they could and how best to deprescribe that. So we decided that Stop Fall was the expert consensus document, that we would use that as our basis. But we found that there was room there to expand it and to make it more user-friendly in certain sections of it. So that's what we did. So as I say, a lot of our time is spent on developing that particular tool. So that's the basis of it. From now on, I'm just going to go through those recommendations first of all, and then we'll go into the guidance document itself after that. Okay, so as we mentioned, the World Fall Guidelines were the first document that we looked for recommendations. But subsequent to that, we had the American Geriatric Society produce their response to the World Fall Guidelines and looked at medication within that. And the group behind Stop Fall had a position paper on it too. And then more laterally, the Australian Falls Guidelines came about, again with information within that on medication review. So we are expecting other guidance. We're expecting NICE guidelines in 2025 on the areas of falls prevention. So hopefully we'll be in a position to use those recommendations to influence our own, but they're not available just yet. So that's where the guidance came from. But I would say, I suppose, if we had a slant at all in our recommendations, it is putting the patient front and centre of them. We did find that evidence was difficult to come by in proving the benefit of medication review for reducing falls risk. So lots of recommendations, and it feels a bit intuitive, I suppose, that reducing a falls risk increasing drug would reduce their falls risk, but it's very hard to come by. And the reasons for that really is the follow through. Deprescribing is a lengthy process. It needs to be planned. And in order for it to be successful, the patient has to be front and centre of it. So the patient needs to be supported, the pathway for this documented, and the patient buy-in is essential. So I suppose for this to be a successful procedure, the patient needs to be in the middle of it, and that's what we have aimed to do with it. So based on that, then our recommendations are very different really to the other ones internationally. We have subdivided them into general, and we have one on primary care, integrated care, so IPTOP, and residential care, and then we go into acute care, so medication review in hospitals in this area, and finally into specialised FALS clinics. So first of all, medication review working group recommendations in general. So medication review and the appropriate prescribing of FRIDs should be done in collaboration with the patient and is an essential component of a comprehensive geriatric assessment. It should be patient personalised and patient-centred. And essentially, you need to consider the patient-specific factors, the patient that you're dealing with, their frailty status, their life expectancy, but crucially, what the patient wants from this process. So what are their goals of care? What do they care about when we're looking at deprescribing? And finally, under the general section, emphasize patient monitoring, support and documentation to ensure the long-term success of deprescribing. Okay, this is quite a lengthy one, but we will get through it. So these are recommendations for medication review across primary care, integrated care and residential care. So the first ones are general considerations before ever prescribing false risk increasing drug. Consider the relative benefits and risks to the patient of doing so, and always include an assessment of the patient's false risk and false history. So essentially, if you're prescribing an antipsychotic, a quetiapine for a patient with dementia, have a look to see what their false history has been recently and what the false risk is there, and then assess the relevant benefit and risk then to that patient of doing so. We recommend review of a pharmacist, ideally with a doctor, but pharmacist and or doctor, of all an older person's prescribed and non-prescribed medications if they've had a fall, when medication has been started or after an increase in dosage, and at least yearly. So all patients at risk of falls should have their medication reviewed on an annual basis. We recommend the use of a structured screening and assessment tool to identify these drugs when performing a medication review, and assess and manage pre-syncope, syncope and postural hypotension, and review medications, including medications associated with pre-syncope and syncope as part of a multifactorial assessment and management plan. Critically, avoid prescribing psychotropic medications if possible. Consider alternative strategies for promoting sleep and addressing anxiety, depression and pain. When prescribing these medications, ensure the starting dose is low, with follow-up planned and the intended stop date documented. Psychotropic medication to be prescribed for the shortest possible time. And a lot of you would be very familiar with that, anywhere from our NG21, the non-cognitive symptoms of dementia management. And finally, again, those of us that would be familiar with residential care and TICWID know this very well, chemical restraint. If medicines are used specifically to restrain an older person, use the minimal dose and regular review and monitor the older person to ensure their safety. Importantly, do not use chemical restraint as a substitute for alternative methods of management. Okay, so they're the recommendations rather of primary care, integrated care and residential care. Okay, so these are the final two sections. The first is acute care and falls clinics. But there's a lot obviously in common with the first set of recommendations there in terms of using a tool, the assessment of syncope, the considerations before prescribing, and these are psychotropic medications. But I would just draw your attention to the first one and the last one there in acute care, which is that a pharmacist reviews all of an older person's prescribed and non-prescribed medications on admission as part of a comprehensive geriatric assessment and at all transitions of care. So swapping between or moving between wards and on discharge. And finally there on that one, communicate any medication changes and suggestions about further changes to the person's GP, which is already in practice, and community pharmacist, which isn't, as part of a discharge planning. Obviously, for this to be successful, the GP and community pharmacists are really brilliantly placed to support our patient in terms of managing any issues they may have with the deprescribing end of things. So they need to be brought into the equation. And falls clinics, a specialist pharmacist reviews all prescribed and non-prescribed medications for any patient prescribed at a falls clinic as part of a comprehensive geriatric assessment. That's principle one there, the use of a tool, the syncope, and finally communicate any medication changes and suggestions about further changes to the person's GP and community pharmacist. Okay, so they're the recommendations of our group in terms of medication review. So I'm going to move on now onto the guidance end of it. Okay, so as I said at the beginning there, we have used stop fall as our basis with very good reason. It was a very ambitious project for our region. It's a screening tool of older persons' prescriptions in older adults with high falls risk. It's validated, it's structured, it's a screening and assessment tool as recommended by the World Fall Guidelines, and it aims to harmonise the practice and guidelines of drug-related falls in Europe. So what Stop Fall did, as I said, was to try and gain consensus about what the experts in the area consider falls risk increasing drugs to be. And they were successful in gaining consensus on these categories. So they agreed that these drugs increase the risk of falls. And those are benzodiazepines and benzodiazepine-related drugs, antipsychotics, opioids, antidepressants, antiepileptics, diuretics, alpha blockers used as antihypertensives and alpha blockers used as prostate hyperplasia, centrally acting antihypertensives, sedative antihistamines, vasodilators used in cardiac diseases, and overactive bladder and incontinence medications. Okay, so there are limitations to stop fall, and the people behind stop fall themselves acknowledged all of these, and it's an issue, I suppose, with the way that they the scope that they were operating within. So the medication classes, we felt, I suppose, we were looking at them, we were trying to apply the document, they're quite broad. So that poses a few issues in terms of identification of the FRIDs. That makes it a little bit more tricky, and also there are quite a few different side effects within different categories. So, for example, all the antidepressants within stop fall are all in one category. There's no separate category for medications within a class. So Prescript in the UK under the NHS did have a go at separating them out. They went with commonly prescribed medications within a class. So we've tried to expand that as well too. Risk of side effects ranges significantly within some medication classes. We touched on that. Also, there's limited guidance and steps for withdrawal. And again, that's really difficult if you're trying to get agreement between so many different experts on how to go about that. But in terms of using the document, that was quite limiting. So if you look at stop fall, it will say consider taper or consider slow withdrawal. But really, the document itself does go into a lot of evidence on that. The deprescribing tool is better, but we felt, I suppose, that we've more guidance since as well too, that we could probably make that a little bit more easy to use. We had a few concerns, I suppose, regarding the appropriateness of providing guidance for certain medications that could be considered specialist. And we have concerns about the appropriateness of providing guidance for the management of certain conditions, because this is going to be a general document, hopefully for widespread use. But some conditions would be better served being managed by a specialist. So we were a little bit worried about that as well too. Okay, so what I'm going to do is I'm going to show you the document itself. Obviously, we have 14 different classes, and each of them have their own section within our document. I'm going to talk you through two, just so that you can see where we started with and where we went with the document and how we arrived at what we did. Okay, so this is the example of benzodiazepines. So first of all, the medication class is as per stop fall. They have medication class as well too. We subdivided it into benzodiazepines and Z drugs for clarity. And we have introduced this category of medications within class. So these are, in this particular one, these are the benzodiazepines that are licensed for use in Ireland. That's those there. We've tried to be as comprehensive as possible. Within this, it's fine, but you'd find any medications that will be used maybe for in a hospice setting. We haven't got midazolam in here, for example, in this category. And later on, the opioids, we might include an alfentanil because it wouldn't be appropriate to put this into this document. But once these are taken out, we've aimed to be as comprehensive as we can do with it. So that was the first section. The second section, when to consider withdrawal. This took us quite a bit of time to work through, to be honest with you, because there's a lot, even though it looks quite straightforward now, there's a lot to tease out in it. The start of it is really from stop fall, if prescribed for anxiety or insomnia. From that point there, what we did was we took the side effects that were listed in stop fall and we cross-checked them for each of the drugs there across the drugs individual SBC and against the BNF to make sure that we agreed with them, I suppose. But then we also did the opposite way. So if we found a side effect that was listed in the SBC for one of those drugs that wasn't included in stop fall, then we looked at to see whether we considered that as increasing a falls risk or having any issue with that. If it was on the very common, it was far more likely to make it than not. But we looked at all the side effects that were listed for each of those drugs. In addition to that, sometimes it was quite difficult in the way that the side effects were reported to know whether or not we could include them separately or whether they were actually already there under one of the headings. So for example, we might have fatigue listed as a side effect for one of them, but did daytime sedation cover that? So there was a lot of toing and froing and debating in the group about how best to go about that. So that's how we rose with that. As you can see, we have an extra little section then just below that where we have asterisks, the clobazam and clonazepam. So if prescribed for epilepsy, you're redirected then into the anti-epileptic section because it's more appropriate to be there for that. And then there's an acknowledgement of clonazepam being prescribed for restless leg syndrome. So we went to that kind of detail where we could. Now the next section on the withdrawal guidance, and we actually brought two sections in stop fall into one with that because we felt it was more succinct that way. So in stop fall you have how to go about withdrawal and symptoms to monitor post deprescribing. So we tried to make it all as comprehensive as we could. Now in this, we looked at several different documents for each of the different sections on withdrawal. And the way we did it, I suppose, if we had an Irish document, if we had a good HSE document, for example, that we were happy with the advice about how we would want to go with it, then that was our gold standard. That's what we would go with. If we didn't have that, or if we felt that an algorithm would be better placed, or there was something that would give us a bit better information, we went with that. So that's very clear in the opioids one that I'm going to show you next. As you can see in the benzodiazepines there, we have a gorgeous HSE document there that talks very nicely through the deprescribing and also has information on withdrawal as well too. So it's a HSE document for the benzodiazepines. We have introduced a patient information. This was later on kind of an addition to the document. We did feel that if we wanted to make sure that the patient was supported and for this to be successful, that we would try and give patient information where we had it. And we didn't always have it, but where we had a leaflet that could be given to the patient or information that would support the prescriber in looking after the patient, then it's in there as well too. So that's those. Okay, and just a quick chat through, this is another example. As I said, there are 14 drugs and they all have different information within them, and you've all had that, so you can work through it yourselves. So this is an example, I suppose, of a slightly different one. This is opioids. So as you can see, your medications within class are there, not including the ones that would be for specialist use in palliative care, for example. And we have the withdrawal when to consider as per the benzodiazepines. In this case, we've gone with a University of Sydney algorithm for the withdrawal of the opioids because it gave a lot of very nice information there. But also the Faculty of Pain Medicine in the UK had a very nice document on tapering and stopping. So we've included that as well too. And just for completion, an opioid dose equivalency table there. So there's a few different resources that may be of benefit. And in the patient information, there's some that's not even really related to prescribing. To be fair, we've gone with Our Lady's Hospice. The opioid transdermal patches is very nice, and the change in routes of administration. So that kind of thing. So I suppose in terms of review and kind of information that we're looking at, we're conscious, first of all, I suppose, that there's a lot of information in this document. It's quite complex in some parts of it, and it may be more appropriate, I suppose, to maybe email any questions if you find that it's quite detailed. The question that you want to put to us is quite detailed. It might be better to send that to us for the whole group to consider rather than doing that today. But we would really value it if there's an area within this that is your area, that you deal with an awful lot. If you feel that you would go with different guidance, for example, or that you're aware of a document that would inform this, that we would be benefiting and incorporating it into it, then we'd be really, really grateful for that as well too. Okay, so I suppose first off, I know myself, if I was watching this, I was wondering, well, how is it accessible? Those are the kind of questions we don't know yet. We don't know if it's going to be online. We don't know if it's going to be available in an app. We're not at that stage yet with this. This is the review part of it. We want to get this bit right before we move on to the next bit. It hopefully is a user-friendly document. It hopefully is useful to us, but your input into this stage would be so valuable to us. we want it to be as accurate, we want it to be appropriate, we want it to be relevant, but beyond all, we want you to be able to use it. So if for some reason it's not easy, that it's cumbersome, whatever, please let us know. Those reviews, Colin has the date on the email that went out, July 31st, please, for all reviews, and we'll get back to you as soon as the group gets back together. So thank you very much. I appreciate that it's a busy hour of a busy week in the middle of the summer, and that you take your time to listen to us is really valuable to us, and thank you. I just want to take the chance here to thank very much wholeheartedly Edel and Colin for superb support the whole way through it. They've been amazing. Thank you.
Thank you very much, Deirdre, for a very interesting and full of detail presentation, as always full of detail with Deirdre. My name is Colin McCann, folks. Good morning. I'm Project Manager with Quality Safety and Service Improvement in the CDLMS. We have a few questions. I'm just looking. It's a few comments, really, rather than questions at this stage. Folks, I would invite your questions. I did send it out through the chat, but if anybody has any questions, please put it in the chat function. We have a comment really in relation to the ID population, and I'll just pass it on to you for consideration at a later date with the rest of the group, but it's specific to anticholinergic burdens and things like that, so it's beyond my knowledge.
Yeah, later actually the guidance there, that's what we're referring to there. Yeah, you can send that to me later on.
Yeah, okay. Thanks for that, Caroline. And we have some just comments. Michelle says thank you. Roisin Daly says excellent work. It'd be useful when the PPT is finalised and circulated. Obviously, Roisin, that would be our better aim. That would be available for every prescriber and everybody else with an interest in it. Roisin again has asked whether it will be regional or national guidance. Really good question. At this stage, we propose it to be regional, but we believe, and actually essentially there's no other work like it, I believe, in Ireland, so potentially it could be national guidance. Do you have any comments in relation to that?
As you say, Colin, that there isn't anything quite like this. Stop follow is what we have on the NHS documents as well too. Whether it be national, I don't know how the procedure that would look like. Our brief is to develop a regional one, but we'll see.
Yeah. Alison said it's fantastic that you're looking at this topic within an Irish context. Excellent work. Thank you, Alison. And here's some from Ailing. Has asked the question, has the tool been reviewed by acute services?
They have been asked, all right, yeah. So this is the review process, and we have asked a review from geriatricians and from all kinds of healthcare professionals, pharmacists as well too. It's going out to OTs and to physios, officers, nurses and staff as well too. It's really important that nurses would give us their take on it. We did have 3 nurses work with us on the group. It's fantastic. They're brilliant. So from a prescribing and prescribing point of view, they would have been involved with us, the nurses there. But in terms of this is where we're at the moment.
Okay. Another couple of comments. Roisin Daly has said, consider adding signposting to a falls clinic and contact details and referral forms on your documentation. Thanks, Roisin. Caroline again has asked us, are GPs involved in this?
They've been asked to review as well.
Yeah, it's been sent out to a number of GPs. And also we have a GP registrar on the working group as well, so they've been involved from that perspective. We have any more? Oh, here's a long one coming in. Okay, thanks. It's in relation to neurological conditions with clients. And basically, it's from an intellectual disability perspective, and they're at higher risk of falls, significant risk of falls in this group, and have considered that in the work.
We have absolutely considered it, and the guidance should be applicable, but I suppose the evidence, as Edel said at the beginning, isn't really for that, you know. So we've used the evidence where we've had it, but it has been in an older person's care. That said, the deprescribing guidelines should be applicable, really.
Thanks. And our comment from Veronica Cafferty, just to say that this is excellent work, very user-friendly guideline, with withdrawal guidance being very useful addition. So well done. A few more thanks. Francis Clear wants to know was psychiatry involved, specifically old age psychiatry.
We have fast review from psychiatry of old age, and from mental health pharmacists as well too. So we have asked for that. Yeah.
And again, some thanks from local government. Any more comments or questions, folks, before we wrap this up? I would encourage you to send any responses that you might have to Deirdre directly. And many of you would have seen the actual documentation that Deirdre was referring to today. If you haven't and you'd like a copy of it, please get in touch with Deirdre. It was on the invite. Or get in touch with either Adele or myself. Again, whatever way you got an invite through this, some people got an invite through a general email. So that would have my email details and Adele's email details. Some people would have got the invite through a specific targeted email, and Deirdre's email would have been on that as well. So please give us your comments by email. If you want to see the document and you haven't yet, please ask for it, and we're more than happy to send it out to you. Okay, if there's no more questions or comments, the last one was a couple of minutes ago, so we'll draw a line under it, Deirdre. Folks, thank you very much.
Thanks very much. Thank you.
Your input and your time, and look forward to hearing some of the comments by email. Thank you very much indeed.
Thanks very much.
Bye-bye.